Good morning. My name is Garth Gibson. I'm the president and the CEO of the Vector Institute for Artificial Intelligence. The Vector Institute is a research body, some 400 researchers with specialties in AI. Both of our speakers today are affiliated with Vector. We are particularly in this era of COVID and epidemics, we're very interested in the problems that society is facing and some of the solutions and some of the technological solutions that are being brought to bear. Vector is pleased to be bringing you this talk. Vector has sponsorship from the federal government through the CFAR, the Canadian Institute for Advanced Research, through the provincial government, and through 47 odd sponsor companies. Today we have a talk on AI in the operating room titled COVID Black Box. And we have two speakers, Frank Rudzicz and Vanessa Palter. We're going to be recording this session and posting it on our YouTube channel that you can find from our Vector Institute.ai website. During this session, please feel free to enter questions into the Q&A box attached to the Zoom panel. And I will be having back and forth questions with Vanessa and Frank, and we'll intersperse your questions into that discussion as we go. So first off, we're going to get a presentation from Frank and Vanessa, and then we will take questions and answers for the rest of this hour. So Vanessa, I think you're starting. Would you please give us a little background and tell us what you came to say?
Thanks so much, Garth. I'm just going to share my screen. Perfect. So thanks again for the introduction. So for the next 10 minutes or so to start things off, Frank and I will be reviewing what the OR Black Box is and how this collaboration between technology, AI, and clinical expertise has been used to help improve the safety of frontline workers, frontline healthcare workers during this global pandemic. So this is somewhat of a strong statement, but it really rings true. The operating room, although it's been the focus of a significant amount of research and study, is really one of the least understood environments in healthcare. And this is for several reasons. First of all, the operating room, of course, is a very complex environment and involves the intersection of care of a range of healthcare providers. So anesthesia, nurses, surgeons, of course, among others. Also, the operating room can be an unpredictable environment where teams change, the status of a patient can change quickly, and healthcare providers are required to act quickly and decisively in complex, evolving situations. The operating room is also where care is provided to some of the sickest and the most fragile patients in the hospital. Although, of course, many surgeries go well, complications and even mortality is not uncommon in this patient population. And although a significant focus of healthcare research is dedicated to understanding complications and how they potentially relate to conduct in the operating room, it's really challenging to drill down and to get a deep understanding of conduct in the operating room and what happens in the operating room, because of the simple fact that there is very little data that exists to allow us to reconstruct in a meaningful way what happens during a particular surgery or operation. For the most part, we're left to rely on someone's memory of what happened while they were in the room, or from data from the patient record. And the patient chart or the patient record has significant limitations. And I like this slide because it summarizes a really nice study that was published in Surgical Endoscopy, I think at the end of 2019, that shows the discrepancy between what's reported in the patient's chart versus what really happened during a case. So what this study shows is that the study reviewed laparoscopic or keyhole surgery cases. And what it shows is that when you review the patient chart for these cases, a very small amount of intraoperative adverse events were noted, only 2% rate of a varus needle injury, and no near misses were noted. But when video review was used and these cases could be examined in further detail, the rate of intraoperative adverse events went from 2% to 9%, And on video review, 35% of the cases exhibited a near miss event. So this takes us to the foundation, or really the idea that sparked the OR black box, which is to essentially, lift this opaque curtain around the operating room and provide a means by which to generate objective data from a clinical environment that can ultimately use to make surgery safer. So I'll pass things over to Frank, and he'll go through in more detail the technology of the OR black box and the role of AI.
Thanks. So I lead a team of deep learning scientists and engineers at Surgical Safety Technologies, and what we're trying to do is to really leverage the possibility of using data in this crucial environment that Vanessa was speaking about. It's very exciting. There's a lot of really interesting tasks we can try to tackle using machine learning and artificial intelligence. Some of which are sort of outlined here. So generally, we want to augment the decision-making skills of the caregivers. We want to improve performance, which includes our technical skill and non-technical skills of the individuals who are giving care. Reduce variability. So a lot of the kind of techniques that Vanessa was speaking about kind of rely on kind of sometimes qualitative surveys that can be very variable, or if not very variable, then just not very useful. So we want to be able to use data to improve educational and patient outcomes. And of course, instead of employing fleets of trained surgeons and clinicians to analyze hours and hours of data every single day, we can use machine learning to analyze these data for us. Can you go to So this is a blood on the slide. So, so if people want to look away for a moment, I'll tell you when it's safe to look. You can. So this is kind of a high-level overview of what the OR black box is. We acquire a lot of information from sensors and other data sources in and around the operating room. So mostly this involves video and audio recordings of surgeries in the operating room. This includes cameras that are embedded in the environment, as you can see in the top row on this screen. And there's also endoscopic or laparoscopic cameras, so cameras that are part of tools that go into the body, as you can see in the lower right-hand side. We started working on some wearable technology on the surgical team. We can monitor patient physiology, as you can see in the lower left, other environmental factors, other devices, and even electronic medical records from sites. Analysis happens. So analysis happens as a combination of trained clinicians and machine learning models, and the outcomes are very varied. We can assess for risks and hazards in the operating room. We can analyze threats to safety and resilience, so ways of avoiding threats to safety in the operating room. We can assess for surgical team performance. How well do teams communicate with each other? How smooth is the operation? We can assess for surgical technology. How well does one stapler or one device work compared to another? And we can also assess for things like efficiency. How quickly does a surgery progress? So the AI team has over a dozen different projects that we have worked on in the past. And I want to summarize a couple of them. So from the sensors we have embedded around the operating room, we can observe a scene and we can track various things in that scene. So this visualization shows what we can do with cameras. You can kind of see that there's some staff around a patient, and cameras can kind of identify where they are. So you can kind of turn them into these skeletons, which are drawn over the scene. If you have multiple cameras in a room, you can actually visualize things in 3 dimensions. And you can use the tracking of people around the environment to figure out like what stage of surgery we're in, if the layout of the room is inefficient, who is doing what. You can also use microphones to hear what's going on. So if people are in a crucial phase where they're communicating with each other and say they're doing a surgical safety checklist and they need to vocalize certain safety checks, we can kind of listen in to make sure they're doing that kind of thing correctly. Next slide. So one of the first things we do is actually to try to promote privacy. So obviously, people, there's something called the Hawthorne effect. So if people know that they're being watched, they tend to behave better. But if, surgeries are part of the record, there is some concern sometimes that it might open up individuals to malpractice or other kinds of effects. So one of the first things we've tried to perfect is the ability to de-identify videos to the extent possible. So these are public clips. We never share clips of our actual data in forums like this. These are public clips of surgeries, but we've applied an older version of the machine learning technology that identifies heads and faces to these videos. And you can see we blur everything out. A newer version of this also identifies the entire body, and it can identify other identifying information. So if the patient has a tattoo, for example, we can also obfuscate that. A lot of this technology actually runs on the site in the hospitals where we deploy. There's more blood on this slide, so we'll look away again. So this is an internal view of a patient during surgery, and we can use machine learning and computer vision techniques to sort of identify what the instruments are doing. And there's various reasons why we'd want to do this. One, we can detect adverse events, so bleeding events where unintended bleeding starts occurring and needs to be rectified. We can detect that, or we can detect thermal injury. If an instrument causes some thermal damage to some tissue, we can detect that also. What's shown here is basically the output of a machine learning algorithm that detects bowel graspers, needle drivers, other instruments, and identifies them. And we can also use this to make inferences about technical skills. So how well the surgeon is moving, how respectful of the tissue they are. These are all things that we're using machine learning to be able to predict automatically. We have a paper out in JAMA Network Open that's currently in press that shows that we're getting state-of-the-art accuracies in detecting instruments in videos of this type, and also using this kind of video to make predictions of technical skill. This is just an overview of one of those aspects. So in the upper left-hand corner is a high-level bird's eye view of the inception-based neural network we use to detect blood, bleeding, burn, and thermal injury. On the right is sort of the rock curve showing the performance of true positives versus false positives. So this is like a state-of-the-art performance in terms of these two. And in the lower left, you can see sort of the ground truth of human analysts identifying blood and bleeding shown in blue over the timeline, and burn and thermal injury in orange over the timeline, and our model shown underneath it. And generally, there's quite a good amount of overlap in these two graphs. So I mentioned wearable technology before. I think, Vanessa, if you actually hit forward, you can see these things being animated. So we don't only do surgeries from internal views, you can also have this wearable camera. So there's a surgeon in our team who also did a degree in engineering, and he actually built this wearable camera based on GoPro technology, which automatically identifies the surgical field, shown here in turquoise, and can identify instruments in the hands and everything, and can monitor surgeries outside of the body as well. So that's kind of an overview of some of the technology we're using machine learning for currently. I'll pass it back to Vanessa.
So the OR black box is designed, as you can tell from some of the projects that Frank provided an overview of, to first of all improve patient outcomes. And this makes sense. If we understand what's happening in the operating room, if we use data to understand what makes a surgery go well and what makes a surgery potentially not go quite so well, then ultimately you can use this data to ensure that you're optimizing patient outcomes across hospitals, across health networks, across countries, etc. The goal of using this data is also to improve culture within teams in the operating room. Our analytics and insights on how teams behave, and again, how the interaction between teams, how communication, leadership, situational awareness can really affect not only how teams function, but again, leading back to patient outcomes, can be used to improve safety culture in particular organizations. And finally, our data and analytics can be used to reduce expenses. So by understanding what makes an operating room run efficiently, how to standardize procedures, and also data with respect to evidence-based procurement can again reduce expenses within a hospital environment. So the OR Black Box right now is installed in a variety of hospitals in Toronto, Ontario, the United States, and Western Europe. And when COVID happened, and of course the world dramatically changed in many ways, especially in healthcare, we saw this as an opportunity to use our existing technology to directly support and provide education for healthcare workers. And just to provide a little bit of context, we know that the rate of infection of healthcare workers is significantly higher than that of the general population. For those of you that look at the Toronto Star, I think a few days ago they were saying that 1 in 5 positive tests are actually from frontline healthcare workers. And data from Italy and from China quote similar numbers of healthcare workers that have been infected during this crisis. And so at St. Michael's Hospital, there was an initiative to train healthcare workers in appropriate use of PPE, or personal protective equipment, which is the equipment that people need to wear in order to protect themselves when they're interacting with or providing healthcare to either potentially COVID positive patients or patients that have tested positive for COVID. And so, as I mentioned, there are black boxes located in the perioperative or in the operating room at St. Michael's Hospital. And we repurposed these black boxes to record perioperative staff as they practiced putting on their PPE, performing high-risk procedures in their PPE, so intubating or extubating a mannequin, and taking off their PPE. And so this slide is a little bit complicated. There's lots of numbers and words on it, but I'll walk through it systematically. So what happened was there was a variety of simulations that were conducted during 1 week at St. Mike's. So this refers to the phase 1 of the initiative. And as I mentioned, the black box was recording all of these interdisciplinary teams, so teams consisting of anesthetists, surgeons, nurses, and also the staff in the operating room that help with the transport of patients and the cleaning of rooms. So these groups did a variety of simulations where they put on PPE, performed an intubation and an extubation on a mannequin, and took off their PPE. And so data from this first week was very interesting. So if you look up at the top right-hand corner of your screen, you'll see a little square that says doffing in numbers. So doffing refers to taking off PPE. And this is one of the highest risk steps for healthcare workers. For those of you that aren't familiar with what people have to do to take off their PPE, it's a very complex exercise. People are wearing masks, visors, goggles, hairnets, gowns, booties, etc. And you have to take these off in a very specific order, perform hand hygiene between these steps. And there's also a very specific technique you need to use in order to avoid contaminating yourself. And what our data showed from this first week of simulations was that only 29% of the participants were able to take off their PPE as specified, which means referring to the protocols that were instituted at St. Mike's Hospital in the operating room at that time. And people were making a variety of errors. Sometimes they were forgetting what order they were supposed to do things. Sometimes they were using incorrect technique. We also kept track of when there was breaches in PPEs during the simulated cases. So that refers to the middle square right at the bottom of your screen. And so just to give a little bit of background, as people are working in the operating room or any real clinical care environment with a potentially infected patient, you need to be really careful. If you touch the patient or something that's contaminated, you don't want to be touching the phone, the desk, your own face, because potentially that might increase the risk either for yourself or your colleagues of catching the virus. So here we were noted during the simulated exercises how many times these type of errors happened. And there were 30 instances across the simulated scenarios. These were 13 simulations where people were making errors with their gloves and accidentally touching a surface or touching their body with a glove that was potentially contaminated. As I mentioned, we also assessed the team as they were intubating the mannequin and extubating the mannequin. So that means putting in the breathing tube or taking out the breathing tube. And there's a variety of protocols that have to be adhered to because, of course, this step is very potentially risky with the generation of aerosolized particles. So very specific steps have to be adhered to. And again, you can see for the most part, the teams performed reasonably well. But again, there were some errors with respect to changing gloves or adhering specifically to the protocols as defined by the team. And then finally, part of our analytics was we're also trying to understand, what made teams perform particularly well during these exercises, and what were the characteristics of teams that maybe had more trouble. And we noted 3 things. One of them was that teams that performed well had a COVID lead, or somebody that took the initiative to really communicate to their entire group, safety, a reminder of safety protocols. They reminded people what to do. They reminded people to change their gloves properly. And these teams, not surprisingly, did quite well. We also noted that when people adhered to the buddy system when they took off their personal protective equipment, meaning that one person simply stood there and coached their partner through all the steps, those people did well and made fewer errors. And finally, we noted that clustering within the operating room, so where people came together in close quarters, there was more potential errors where people either contaminated themselves or contaminated their colleagues. So this data was communicated back to the perioperative group, so to the nurses, surgeons, anesthetists, PSAs working in the operating room, as well as to the educators running these simulation scenarios. Also, this data was made into a poster that looks the way it looks right here on your screen and was plastered all over the operating room, with the idea being that improvement, again, can only happen with data. If you know where people are struggling, or as an individual where errors are happening, where to focus your efforts in order to reduce these errors. So phase 2 of this initiative was after this information was communicated back to the educators and put up in the operating room and communicated to staff, we continued to record more simulation exercises. And the results were great and very encouraging. So I'll direct you back to the doffing in numbers square, which is the top middle square of your screen. And you can see that people from week 1, where 29% of people knew what to do correctly, by week 2, 74% of people knew what to do correctly. And the numbers of errors per person went from 1.6 to 0.3, so big improvement. There was also significantly fewer breaches in PPE or infection control during the simulated scenario. People in general performed better during the high-risk intubation as well as during the high-risk extubation. And again, we made notes of, again, what teams went well, what teams struggled and made errors. And again, this data was communicated back to the team, to the clinicians on the ground, so they could use this data to educate their staff. Next steps from this is we did similar data capture and provision of analytics to multidisciplinary teams from the ICU at St. Mike's. And the idea is to expand to other clinical care groups in the hospital. So the last few slides just provide an overview of some of the partners that we have here at Surgical Safety Technologies with the OR Black Box, as well as an overview of the hospitals and academic centers that either have OR Black Boxes in their clinical care environments or will be getting them this year in 2020. And finally, the OR Black Box was named as one of Time Magazine's best inventions of 2019, which again speaks to this idea that, over the past few years, I think we've, not just within the healthcare community, but within the broader community, understand that data and transparency really is the foundation by which to improve patient safety within these high-risk clinical care environments. So thank you very much. I will stop screen sharing here.
Thank you, Vanessa. Thank you, Frank. I just want to start right off the bat. First, invite everyone to submit their questions to the Q&A, but right off the bat, I want to know how far you're going with this. So I hear that you're using tools to help in the COVID scenario, the training of individuals to protect themselves when they're working inside the hospital. Is that correct?
Yeah, exactly. So this started as that initiative within the group in the operating room, so the people that will be providing healthcare for patients that need surgery. But the idea, of course, is it's not just a problem in the operating room, it's a problem potentially really anywhere within the hospital. So expanding this data and these analytics to all the care groups within hospitals, of course, is the next logical step.
And so is there, so I think about airplanes, right? So I can have a display that draws my attention to the things I should be paying attention to. I can have warnings that say the machine says I need to do this now, and I can have autopilot where they just do it all. And so are you in the stage where the tools provide a display to speed up the human understanding of what's going on? Are you telling the human, I think the answer is, or are you just counting the number of times that someone does it wrong and reporting at the end the failure rate of that individual?
So I'll start by answering maybe, and then I'll let Frank provide a bit more insight. So right now, we are in that delivery of data phase. So I think because we're coming from a place where the data simply has not existed, step one, of course, is just figuring out what's going on, understanding data and understanding the relationships between data. So using the OR as an example, right now it's very opaque. We don't really understand necessarily in a very clear way the relationship between intraoperative events, intraoperative adverse events, complications to patients, how situational awareness, leadership, potential distractions, how all of these data points mesh together and then ultimately can lead to an outcome. So step one is understanding the data, sort of giving a picture of the landscape and identifying potential pain points. Of course, the next step, and I think you alluded to this, this is the really important step, is then the ability to provide decision support to the clinicians actually working in that space, allowing them to, you know, a red flag, a light goes on, something to anticipate that they are at risk of making an error, they are at risk for a particular reason, and allowing them to stop, you know, take a moment and redirect course. And I think this is really where AI and data science and big data can ultimately change the face of how we provide healthcare. Mm. Frank, I don't know if you have more to add.
No, I think that was excellent. I'll just say, like right now, like full automation, full autopilot is not really something where we're aiming towards yet. Although there's been like 1 or 2 papers in the past that have automated surgery entirely with robotics without human intervention for very limited tasks on very simulated data. But that's not really our wheelhouse. Like we're really trying to, you know, follow the data and make the data available and useful. Clinical decision support and real-time clinical decision support is something that interests us greatly. But it's sort of like machine learning has traditionally kind of looked at data that's already been recorded, you know, on our servers, and we provide analytics after the fact. But connecting machine learning into practice has this gap, which involves human factors, right? We don't want a system has to be able to behave in the real world because it's going to have an effect in the real world. No longer are we just reporting accuracies in a paper, but if a machine learning algorithm makes a mistake in real time and people have to respond to it, or if they're distracted by it, that could potentially be deleterious itself. So kind of taking machine learning perspective, taking the clinical perspective and combining them with human factors is sort of the last mile. And that's something that we're really excited about pursuing.
So Frank, you're touching on a question Danny R asked about the 2 or 3 most important research directions that you're currently working towards. And I heard you talk about your interest in increasing the live feedback in the system. Is that one of them? And what are the other most important research directions that you're working on?
I think the live feedback is part of an umbrella of technologies that are around explainable AI. Explainable AI is a new kind of sub area of machine learning that you know, came in response of some challenges in machine learning. Like we need to understand what these black boxes are actually doing on the inside. But as a lot of us know, there's a lot of controversy around the field of explainable AI if the methods themselves are sensitive or not robust. You know, how do we actually use them? But there's a lot of benefit there anyway. So we're interested in you know, if we're going to make a suggestion, or if we're going to say this is where the bleeding is, or this is where your team needs to improve, it's something that's actually not just assessing, but also actually trying to help with intervention. Explainable AI is going to be a crucial component to that. We have to be very careful because explainable AI, even though it's trying to be a solution to a problem, it can also potentially have challenges itself. So that's like one is explainability and usability, which again comes back to the human factors aspect. I'm really interested by the kind of multimodal nature of the data we have right now. Like a lot of the examples we showed before are usually kind of unimodal still, and a lot of machine learning and surgery is still unimodal. So like we have a camera inside the body and we look at the instruments. But if we're also simultaneously recording video outside, the body and then the room. We can kind of tell, okay, there's a distraction event, like someone's going in and out of a door or something during this crucial phase. You can't see that from the video inside the body, but you can hear that and you can see it from the external view camera. So it's not exactly full research. It's kind of in that area between deployment and research, but like how do we actually integrate multiple sources of data to give us information that no single source of information can give you is really interesting to me. And part of that is speech and language. I didn't talk about it very much here, except as a side note when we're looking at the external view camera, but there's a lot we can potentially do with language also in not only clinical notes, but in the operating room. So can we hear for signs of stress or uncertainty in speech? That's super exciting to me. I'm biased because I've been doing speech recognition since I was like an undergrad. So I've always found it really fascinating. It's very challenging. So again, I've been doing speech recognition for a long time, and the operating room is probably the most challenging area to do speech recognition I've ever encountered. Like there's music playing and people are whispering to each other with their backs turned to the microphone and they're using technical language and there's multiple people talking and there's instruments beeping and everything. So it's super challenging, but there's still like, there's a needle in the haystack there and you can still pull out useful information that could be helpful to you know, help with the decision-making process. So there's a ton of stuff. Really, the challenge is focusing. There's so many things we could potentially do. And right now we want to focus on those things like right in front of us to make some impact in the short term.
So Vanessa, when Frank starts speaking about things like understanding what's going on in the speech in the OR, is it your experience that the clinicians are eager or nervous? And what factors do you think are going through their minds on these questions?
I think in general, people are eager to learn more in the sense that no matter, you know, what your professional role is, you want to be doing better, you want to do your best, you want to be providing the best care you possibly can. And sometimes the operating room, as Frank has sort of spoken about, it is an unbelievably complex environment. And it's sometimes very hard to tease out the relationships between data. So understanding, you know, you read these papers or you look at studies and they're very unidimensional, you know, either music is good in the OR or music is bad, or, you know, these things are distracting you, or maybe they're not. And I think what's lacking is understanding how that data all fits together. So, you know, perhaps music and people chattering is actually okay when things are going well, but in a more complicated part of the surgery, perhaps that's when those, you know, you need more situational awareness. It's more of like an ebb and flow. And I think that giving clinicians the clarity and the ability to understand actually how their work environment functions and what makes it function well and not well, then actually gives you the tools to enact some of those changes. I think sometimes you can feel a little bit helpless in the sense, you know that being a good technician will result in a good outcome, but you also know when you have that innate sense that there are so many other things that contribute to that, but it's hard to sort of pin them down. And so I think knowing that data, understanding the relationships can actually provide clarity to people in how to best improve. And it's certainly, that's been our experience when we're talking to clinicians and showing them some of our data. It's sort of like that aha moment, like, yes, we want this understanding, but it's challenging to get to it.
So let me ask that again in a more focused way. So
sure.
Do your clinicians worry that this data can be used to increase the number of lawsuits that that come against them?
So we also get that question as well, absolutely, from, you know, everybody within that particular healthcare environment, clinicians, nurses, et cetera. And what we sort of, the information we convey back to them is that we do our utmost, of course, to respect the privacy and make sure that we're doing this in the safest possible way. The idea, of course, of this data is to improve care, not to provide risk to any particular clinician. So we have a variety of strategies in place to ensure and to try and mitigate that risk as much as possible. So all audiovisual data is deleted within 30 days of capture. The only things that are retained are the analytics or completely anonymized data. So that's would refer to the internal view from the laparoscopic camera, for example, where it's impossible to identify somebody. And one of our partners is the CMPA, which is the Canadian Medical Protective Association. And certainly the messaging from them, at least, is that unless, of course, there's a criminal act in the operating room, as long as the data is deleted within 30 days, that's a very reasonable time frame to ensure that should a lawsuit happen in the future, the data is not retrievable.
Okay. What about, how does the patients feel about the notion that that you're deleting the data they might use in a lawsuit against the doctors?
So the patients actually love the OR black box, and the response from patients and from patient advocate groups have been very supportive. I think, again, because for them, they're in a very vulnerable situation. They're asleep, they're having their operation done, and they want that sense of that the clinicians have a way in which to learn from what happens, the way we all do with continuing professional medical education and stuff. So the patients in general have been very supportive. And to answer your question specifically, I think, everybody is understanding and aware that there is a certain sacrifice of your personal privacy to have this either in an operating room or a clinical space. And so there's that understanding of the fact that in order, for this to be accepted within the medical community, for it to have use, for us to be able to deliver the data in a meaningful way, deleting the data within 30 days is also, or deleting the identifiable data within 30 days is also important to ensure that, that this initiative is able to go forward.
So you think that's the right trade-off between
I do.
window opportunity for consideration and a long-term liability of some kind of ancient case being brought up and used against you?
Yeah, I do.
All right. So Frank, this is an AI community here. So let's talk a little bit about what's going on. Lots of AI is basically about modeling and prediction. So what are you predicting, and how is that? What is that modeling in order to derive those predictions?
So I mentioned a couple of the things that we're looking at actually predicting. Some of them we've published already, so I can talk about those first. So this can include adverse events. So if there's a kind of I'm going to say accident, but if there's an event inside the body where there's like unintended bleeding, or the instrument makes a thermal injury, these are highly correlated with outcomes after surgery that are not necessarily optimal. So we want to be able to detect adverse events, and we can use a computer vision from inside the body. Typically, these are combinations of CNNs and RNNs, or CNNs and some other temporal processing. And there's annotations. So we have surgeons and clinicians on the team who have already kind of given us the label, so everything's supervised. Similar to, again, from an internal view, we want to assess for technical skill. There's these rating scales that are standardized and used quite a lot, and these include things like efficiency of motion, how efficient are they, or how smooth is the operation, how well do they respect tissue, how well do they use the camera in combination with the instruments. And those are also given labels from surgeons. And so again, it's a supervised task with CNN, RNN hybrids or something similar typically.
My experience with surgeons, it's pretty hard to ask them to label videos from the past. That you get a very small number of those. So how can you do really good AI with a very limited amount of manual labeling?
So we actually have a really good, one of the reasons why I'm excited to work there is we have a wide range of clinical analysts, people with advanced medical training, and they're going through cases constantly. So sometimes they often tend to focus on the things that are beyond AI currently, so things that require some more contextual, ad hoc reasoning or wisdom that is still kind of beyond the reach of modern machine learning. But they also are they're already annotating some things that we can do. So I kind of think of machine learning generally as sort of, it's very easy to solve things that humans can do in an instant. So if you can tell, if a trained surgeon can tell if it's unintended bleeding, they can do it in an instant, but it takes them a lot of time to do it, right? So they're doing it already. They're already looking for adverse events. They're already kind of assessing for technical skill. They're already chopping up a video. So like there's like dozens of different critical periods in a surgery. And we want to know, like, are they doing the surgical checklist I mentioned earlier? How long does the procedure take? How long do these subsections take? So they're already kind of annotating things in time too. But like individually, it takes them a second to, like, a trained individual to tell that this is not good instrument handling. So therefore AI might be applicable in that situation, but like added up, it's a ton of time for them. And even though we have a large number of them providing their labels, I think one of the first things we want to use AI for is to take some of the burden off of them so that they can focus more on the aspects of the surgery that still require human sort of wisdom. And then AI kind of automates the stuff that they have been traditionally annotating. We have a lot of data for already. Like we have as Vanessa mentioned, we have a ton of data that if you look at the literature, hasn't really been approached yet. We have a ton of labeled data. Sometimes, well, one last thing is we have to kind of like have this like modern methods for adaptive training. So sometimes you have to combine labeled cases with unlabeled cases, either in that order or in the other order, and kind of do an adaptive type training to improve performance without necessarily having to have every single piece of data labeled.
So you gave examples of classifying events, but I think you earlier talked about recognizing faces, recognizing tattoos, identifying what was that all done on supervised data training, and is that all from OR, or did you were able to use models from other forms of life or practices of video recording that allowed you to fine-tune your models inside the hospital?
Yeah, that's a great question. Actually, some of our people who work at the company are also PhD students in computer science. And one of the research directions, to answer the question from before, that they're pursuing is sort of what are these models actually representing? And how can you use like supermassive data sets generically as kind of a pre-training phase, and then kind of fine-tune them with surgical data? Because even if we have a ton of data relative to the surgical field compared to what's available in computer vision generally, it's still relatively small. So we want to be able to adapt massive open data sets, train models first to identify things that they care about, and then adapt it to things that we can label quickly. Fortunately, there's a lot of overlap. So a lot of these open data sets that are massive have people in them, or they have things like monitors or chairs or beds. And we have those things in the operating room, and we can kind of ignore the things that we don't have in the operating room, like bicycles and dogs. But it's also very tricky. We have to be careful that we're not, or typically anyway, we have to be careful that we're not, like, what is it that we're actually representing, and what is it that the machine learning has learned in the first place, and how do we adapt it without losing useful information and without kind of overfitting. So it's also like a big engineering challenge, but it's something that is pretty well understood in the community at this point.
So Vanessa, medicine is full of careful comparison, randomized controlled trials. How are you evaluating the improvement? I mean, what is the prior case? How do you compare to the prior case when you evaluate the technology and its accuracy and its utility?
So I think stage one is very far removed from a randomized controlled trial, which would be you put the black box in a particular institution, you get a baseline measurement, and then you sort of, because every context, every hospital, every environment, every stakeholder, they'll have different pain points. So for example, they look at all their data, they notice the number of doors opening and closing is way higher compared to, either what they expect or potentially what's going on at other institutions. So then they do a QI intervention. They want to see, can we actually affect change? So then they change something and we continue to measure. The black box stays on and we can look at a pre and post. So that's sort of stage one, is understanding, A, what does my data look like? And then B, if I do an intervention, does my data change? Then of course you want to be moving to more, to larger trials, to multi-center trials, to understand, understand some of these bigger questions. But I think right now what's interesting here in this space, at least, is that the data is so new. A lot of the randomized control trials in medicine are in, in more medical specialties. So, oncology, comparing drugs, cardiology, et cetera, et cetera. But within surgery, there's actually very few randomized trials. And I think, again, it's because of, the environment, it's because of the patient population. It's very hard to do randomized trials with surgical patients for a variety of reasons. And I think, again, it just speaks to the fact that without a strong data foundation, it's hard to even get to the trial phase. So right now, I think the really important studies are just are essentially QI interventions, and then taking it, on a stepwise progression through there, rather than sort of jumping to the big guns right at the beginning.
So it also sounds like this is a deep partnership with the clinicians involved.
Absolutely.
To convince them that they want to use this as a tool for their quality improvement, as opposed to an entire solution coming in from the outside.
Absolutely, absolutely. And I think that's a really important point that you touched on. Data is only as good as the people that are interested in it and how you use it. And without that partnership, without the local stakeholder involvement, this data is going to do nothing, right? Just measurement isn't going to change anything. It's measurement, understanding what's working, what's not working, and then targeted interventions.
With self-driving cars, we have become very concerned about the car doing so much of the driving that the driver's asleep or lazy or not paying attention, and that the quality of the human intervention in order to protect the overall quality of the experience drops because the tools are doing so many things. Is there a similar phenomena you're concerned about, or is that just not on the table yet?
That's a really good question. I think in medicine, specifically in anesthesia, there's actually some data that suggests that clinicians do actually need this downtime, or this time where they're not focusing, where they can let off steam and chat and essentially be distracted from what's happening in front of them. And you can imagine you're doing, a 12-hour complicated operation. Not every second of that operation does require your full attention, and your cognitive load can simply get overwhelmed if you have to be on at 100% during the whole case. That being said, distraction, sleeping at the wheel, while things are critical, of course, can have disastrous outcomes. So I think to answer your question, I think we don't know enough. I think it actually would be really interesting to understand more when we can safely let our attention wander, to allow us to then come back to that high cognitive load in a more data-driven way, as opposed to like a more intuitive way, which naturally happens in the operating room. It's normal to have conversation between colleagues, but you just want to be doing it and sort of shutting your mind off at the right time, as opposed to at a random time. So I think in general, working in such a high stakes environment, I'm not worried that things will become so automated you'll lose attention completely. But I think having some guidance as how to direct your attention would be very beneficial.
Frank, you're dealing with video, you're dealing with recognizing people's faces. There's a widespread discussion about bias in the technology, and that in diversity or race can play a factor because the training data wasn't appropriate. Do you have similar problems, and what do you do about them?
I think even if we don't observe those kinds of problems yet, like, we have to assume that they're there because sometimes these things can be hidden from view. So we always have to assume that there's some kind of bias, and we have to also understand that sometimes the bias might not be something that's usually easily categorized. Like, it's sometimes just not just one demographic factor, but it's a combination of things. So that's always a big concern of mine, because there's a lot of papers in machine learning that came out that touted these wonderful results, and then a few months later, it's revealed that, well, it only works if their skin is white, or if only works if you speak English, or something like that. And like I said, we haven't really observed anything yet, but where we started looking at some of the medical records, and there's this idea that sometimes there's a effect of the patient on the nature or the quality or the information that's stored in the surgical note. And it could be unconscious, but sometimes it might be, say, shorter or more somewhat less informative than other cases. So we have to always assume it's there. Our group at Vector actually has done a lot of work in detecting bias and in mitigating against it. And hopefully we'll be having some cool new results to talk to you about soon. But there's a lot of techniques that you can do to identify bias in the first place. and minimize bias while still kind of maintaining a robust, accurate system. So I think generally our approach is always to assume it's there, apply bias mitigation methods, and monitor.
You know, as we get closer to the end of the hour, I want to ask more wide-ranging questions if I can. You made a reference to the ability to neglect bicycles and dogs. It does seem to me that black box in the wilds should be possible, even if it's just emergency services starting to try and use the similar technology. So does it get much harder? And would you say that you have a lot of work to be able to take black box into the wild?
I'll start maybe, and then I'll let you say your thoughts, Frank. So I think right now, the black box is in very defined clinical care environments. It's in the operating room. There's a door to get into the operating room. It's in the trauma room. There's a door to get in, you know, et cetera, et cetera. And before we bring the black box into any hospital, there's a lot of information. It doesn't just appear one day. So all the stakeholders are spoken to. Everybody's aware of what it is designed for. And specifically the idea that while people are being recorded, the data that's reported back is aggregate data designed to, improve care across an entire group of people, not designed for individual assessment. And so in that sense, it's somewhat contained, very transparent. I think as you move into, even into broader areas, potentially within the hospital or outside the hospital, it becomes much harder, first of all, to educate the people that might be coming in and out of that space with respect to what the technology is. But also, I think it's also very important to be very clear about what the motivation is and what the goal is of the data and how the data would actually be delivered back to the people participating. As I spoke about it earlier, of course, people are compromising a little bit of their privacy in order for what they see as the greater good. And so, outside, again, a very defined environment, it has to be very clear how their compromise of an individual's privacy, again, would be, would either they or a group would see a benefit of this. So I think it's important to just be very thoughtful about all of those things. Yet, of course, is something that I think, in general, we're progressing more and more towards in the future.
So maybe not the EMS field unit for a while, but what about the courtyard at the hospital when your clinicians are taking a break, they're doing for emotional health, and they go out into the courtyard and, they partially remove their COVID gloves, and is there an interest in actually, let's say, helping them by observing their less focused time periods to see whether or not there are issues there? And is that treading on their privacy? And how are you facing those issues?
Yeah, so those are great questions. Again, I think it just really speaks to this. It's important from both, our end, the company end, but also from the stakeholder end. What are the goals? Like, what is the purpose of the recording? Is it in this time of COVID, we need to be potentially recording the whole hospital to ensure that people are abiding by, I'm just giving an example here, whatever the hospital has decided is appropriate, everybody wearing a mask, for example. Again, I think, it's just a bigger challenge because more stakeholders need to be educated, more people need to understand, why the cameras are there and what the purpose is. And I guess a smaller analogy would be from us moving from the operating room where the people in that space are very defined to the trauma room where there's more people. There's, not only doctors, nurses, there's doctors and nurses from many different specialties, anesthesia, orthopedics, neurosurgery, general surgery, but there's also people from the outside world, police officers, paramedics, et cetera. And so again, we've been successful in being able to implement it in the trauma room, but it requires stakeholder engagement. And again, just the appropriate education. But I think with the right questions and the right goals, this is something that's very important.
I see one of our attendees has asked the classical academic question. Now that you've put the effort to gather a lot of data and label it, would you please open source your data so that we can all compete with you on the technology of our models? What's your attitude towards sharing your labeled data?
I think that's a good question. I think we're still kind of trying to figure out what that's going to look like. In some cases, when there's like students doing some work kind of on the periphery of the company, there's already kind of the idea that things are going to be more academically transparent. There is possibility of code being shared. Like one of the former students who's now in the company is preparing a paper based on her thesis, and part of that's going to involve open sourcing parts of it. The data is another question, right? Like we can't, like a lot of our data is recorded outside of research ethics, and we can't, like it's part of quality improvement in a hospital, for example, and there's just no way to open source the data. Or if it is part of research study, people explicitly consent, and they don't consent to putting their liver online. But we have talked about challenges in the past, right? So there's the company, and then there's the academic wing, and we're interested in sort of open sourcing small chunks of it to these kind of annual challenges. There's some groups that have approached this for surgical technology, and it's really exciting to get everyone involved. And I think it's something that we've wanting to do for a long time. It's just sort of like trying to find the time to organize such a thing. It's challenging. It's not like just scraping Twitter and or scraping Reddit and putting that information up. It requires a lot of administrative hoops we have to go through.
I see also a question about remote healthcare, remote surgery. Are you part of a solution to make it possible for a operating room in Nunavut to be driven from a specialist in Montreal?
So that's a little bit outside of what we're doing, in the sense of, right now we are collecting data from an operating room, from a clinical care space, and delivering it back to that individual. So absolutely, this technology, the black box, can be put in any hospital across, whether it's in a big city or in a more remote location. But with respect to the idea of surgical coaching or AI providing decision support, et cetera, we're not there yet. But absolutely, we would be able to support, any type of hospital, essentially.
Okay. The type of surgery is an issue. So do you train for each type of surgery, a cardiac versus knee surgery versus others? And is it an exercise of classification and development of new tools, or are there sort of broad techniques that apply in all of them?
So yeah, we do have to kind of know what the surgery is beforehand. So usually this is obvious, like we can get it directly from the medical record, or any other kind of metadata about the surgery. So normally we know what type of surgery is going on, and typically we've been training AI for these different types. You can, like, again, this is pretty standard now to do something like meta learning, where you have a lot of different specific things you're looking for. You might have a collection of open surgeries and a collection of minimally invasive internal surgeries that all differ in various ways, but they're also all similar in other ways. So you can kind of combine this training mechanism where you can learn a good default model that is good across open surgeries generally, or it's a good starting point for open surgeries generally and internal surgeries, but then we can kind of fine tune. But in all cases, we always know what the surgery is in the end.
Okay. Now, as we come to the end here, tell us about your company and your aspirations for this company and the technology. What are the opportunities? If there's someone out there that's thinking about talking to you about labeled data or applications, which ones are you most interested in pursuing?
I'm looking at Vanessa.
Sorry, sure, I'll go ahead and then
I can give it a shot if you want.
Sure, go ahead, and then I can chat.
Yes, you can fill in the massive cracks. So like I said earlier, like the sky's sort of the limit. Like there's been very little like data-driven, technology-driven work in the operating room. Like Vanessa started off the hour talking about how little understood the operating room has been traditionally. So the main thing is now like opening up the black box of healthcare and really studying objectively everything that goes on. And as I mentioned during my piece, like there's too many things that we could potentially do that right now we have to focus on a handful of things that can have like immediate benefit. Like we're deploying this and people need to know X, Y, and Z are the most important things. But there's a ton of other tasks that are going to be relevant to us. I think like eventually, I think we want to kind of do everything that makes sense. Like the fundamental goal is just to make surgery safer, right? To have fewer errors and have better outcomes. And however we can achieve that, we're going to pursue it. And as we grow, we'll have more and more data coming in, more and more resources to pursue like things that we aren't even pursuing now. So like, and you mentioned earlier, Garth, like we have this sort of, right now we're starting off with a kind of a traditional data-driven approach where we record some data and we use data science or AI to assess or diagnose what went wrong or what went right, and then kind of report things to the user. The next stage is sort of interventional, you know, so how can you actually help with real-time support? That's a huge area, technically, clinically, that is on the horizon. And then, but beyond that, who knows? I think like we have a lot of great work under our belt and a lot of good next steps that are going to be happening. So like the sky is basically the limit as far as I can tell.
So Vanessa, you have the last word.
So I guess what I would say is, you know, right now, of course, we're focused on recording in the operating room, in the clinical care environment. I think really the next exciting step is linking that data to other data with respect to a patient's journey. So, you know, somebody comes to the OR, what's happened to them before they get to the operating room? What happens to them after the operating room? What happens to them, you know, 2 months later when they go to a different hospital? I think, you know, taking things to the next step and linking our data set to other bigger data sets is going to be really exciting and the way we're hoping to move in the future.
Okay, thank you both, Vanessa and Frank, for giving us this interesting discussion today. And I'd like to see the technology and the use of technology in healthcare. And it's fabulous, and I understand that there's lots of opportunity for improvement, and there's lots of interesting questions coming down the line. So please continue to advance it and come talk to us from time to time about what's evolving and what the important problems and advantages are. Thank you all for coming, and thank Vector sponsors for making this possible. This video will be posted on our YouTube channel in the near future. Have a great day.